Welcome to our seventh session of our CPD sessions with our mini lectures. And today the focus is going to be on hamstring injury. And first to speak up is Dr. Ronan Kearney. He's a consultant sports and exercise medicine physician at UPMC Sports Surgery Clinic in Dublin. He's been involved with multiple sporting organisations throughout his career, including Sport Ireland Institute, European Tour Golf, GAA. He's completed his medical training at the Royal College of Surgeons in Ireland and specialised further in sports and exercise medicine with an MSc from Trinity College Dublin. His extensive experience as a team doctor, including soccer, rugby, GAA, athletics and rowing. He serves as an associate editor for the BMG Open Sport and Exercise Medicine Journal, lectures at Trinity College Dublin and University of Limerick, and recently attended the Olympics in Paris as a team doctor for Ireland. So very surprised, Ronan, you have time to talk to us today, but glad to have you with us. And Ronan's going to speak now. If you'd like to share your screen there, Ronan, thanks very much.
Brilliant, Pat. Thanks very much, and thanks very much for the invite as well. Delighted to speak on a topic that I actually really enjoy speaking on as well and looking after as well. So I'll speak today on hamstring injury assessment and diagnosis. As Pat said, I've been involved in a number of different sporting organisations and whatnot, and hamstrings really are, I suppose, a key injury and a huge injury in a lot of field-based sports and also in athletics. So we'll talk a little bit of a background of hamstring injury. We'll really focus in on the anatomy and the physiology of healing. But really what I'll try and hone in on this talk is on the assessment, the clinical and radiological assessment, and some tips on that. So firstly, background history of hamstring injuries. So those of us that work in sport know that it's a huge burden injury. 17% of all GAA hurling injuries and almost 25% of all GAA football injuries are hamstring injuries. Similar numbers for elite soccer, rugby a little bit less, and then track and field a little bit less, but still a huge burden across the field. The burden is increasing. So from a large UEFA study, the incidence has increased from 12% right up to 24% in the last 20 years or so. So why is it so? A third of injury-related time loss in the GAA season are hamstring injuries. Generally, the time away from play in the GAA field will be about 26 days and almost 40 days in elite rugby. And so if you have a panel of 30 GAA players, expect 9 of them to have a hamstring injury per season. So huge impact. And we know that teams that lose players through injury are obviously going to have a less of a performance effect overall. And this was a nice study on the UEFA teams that those who had increased injury rates had negative net effect on performance. So hamstring injuries risk factors. So I suppose there's multiple risk factors across multiple different domains really, and just to really try and narrow it down to maybe some of the risk factors that are maybe a little bit better researched. So some are obviously modifiable risk factors and some are non-modifiable. So we can't change your age, unfortunately. We can't change your injury history. But interestingly, if you've ever had a previous lower limb injury of any sort, it trebles your relative risk of a hamstring injury. Having a previous hamstring injury, either on the same side or the opposite side, again, trebles your risk of hamstring injury. So we really should be looking at these type of individuals and trying to implement injury prevention programs. There are a number of biomechanical factors that increase the risk of hamstring injury. If you've got reduced hip extension, reduced passive knee extension, ankle dorsiflexion, if that's reduced, you have a significant increased risk of hamstring injury. Hamstring length is an important factor in risk factors also. Neuromuscular control, which is a focus of many of the hamstring prevention exercise programs. With poor neuromuscular control comes increased risk of hamstring injury also. It's well published that a reduced eccentric hamstring strength is a large hamstring injury risk factor. And we do follow this very closely in both rehab and management. There is a thought that maybe the quadriceps or hamstring to quadriceps strength ratio of less than 0.6 might be a factor as well. There's been many studies published on the training load and the acute on chronic ratios and what's the optimal ratio. But it seems to be that chronic exposure to high-speed running actually is quite protective for hamstring injuries once appropriately dosed. Lack of recovery comes in many different guises, including fixture schedule, including travel to and from training, including lack of recovery days during the week, which we all see from many different sports seems to be more and more fixtures with less recovery. This is obviously another risk factor. But there's others. The psychology of injury is a huge factor that is often ignored. And hamstrings, especially those that have recurrent hamstring injuries, almost always there is an impact to their psychology and their fear of movement. This needs to be addressed as well. Interestingly enough, if a team has a new manager, their hamstring injury and their general injury risk increases as well. Poor communication amongst medical teams to coaching teams amongst teams, again, is another significant injury risk factor. So look, really, this is a broad slide crossing lots of different domains, but just to give us a flavour of not just the mechanical risk factors, there's others out there as well. Every week, maybe because my social media and whatnot I get ads on hamstring injury risk factors, and there seems to be a new program every week in terms of what's out there. But this was a nice infographic that came up recently, and it essentially summarizes a nice systematic review published in 2022 from the American Journal of Sports Medicine, and covers 6 main domains in terms of risk factor injury management and risk reduction. And a number of different, we won't go through it in detail, but really a number of different mechanisms to, one, improve your concentric strength, improve your eccentric strength, improve your fascicle length, reduce limb asymmetry, and then improve flexibility. So there are well-published studies out there across a number of these domains that can reduce the risk of injury. Let's talk about the anatomy and physiology of hamstrings now, which really is vital to understand the injuries. So skeletal muscle, the hamstrings are made up of both skeletal muscle, obviously, and tendon tissue, and they're both very different tissues. Skeletal muscles are made up of contractile elements and non-contractile elements. The contractile elements are the actin myosin cross chains, making up the sacromeres, and then on the more of a macro level, we have fascicles, perimysium, epimysium, and endomysium, connective tissue. And skeletal muscle heals very differently to tendon tissue. So muscle, after an injury, you get cleanup in macrophages, clean the necrosis and hematoma in this inflammatory first stage. Generally, that takes place in the first 5 days or so. Regeneration happens next, where the biggest difference is the satellite cells, which are the progenitor cells of new muscle fibers, flood into the tear and start to create new myofibrils. You then get remodeling over time, where these regenerated myofibrils start to mature. You get contraction of the reorganized scar tissue, and then eventually there's a recovery of the muscle functional capacity. This can take up to 8 weeks. If there's incomplete healing, there is a risk of fibrotic scar formation, and a fibrotic scar in a muscle leads to impairment of function of that muscle. Tendon tissue is very different. So tendons respond and adapt to mechanical loading. Tendons don't recover with rest, unfortunately. Tendons are made up of type 1 collagen and type 2 collagen. Type 1 collagen has a very high tensile strength and is far greater in its capacity to withstand load than type 3 collagen. Type 2 collagen and proteoglycans are much more of a viscoelastic property to allow that kind of suppleness to the tendon itself. All tendons have a barrier whereby if the stress and strain is exceeded beyond that barrier, will rupture. And thankfully, these maximal capacities of the tendons are very, very high. However, we know when we have an acute tendon rupture, this is when that stress or strain limitation is exceeded. There can be microscopic failure over time, where there is outside of the physiological range of the tendon's ability to adapt is overreached. And this is something that we see commonly with overtraining. Tendon healing is quite different than muscle healing. And the main difference really here is that tendons don't have their own regenerator cell. They don't have satellite cells to create new tendon tissue. So it takes longer. They have the initial inflammatory stage in the first week or so, where you get hematoma formation, cytokines release, growth factors inputted into the injury itself. Type 3 collagen makes up the initial collagen granulation tissue. And we know that type 3 collagen doesn't have the same tensile strength as type 1 collagen, so therefore is at higher risk of re-injury. A tendon callus is formed, and that is largest generally at week 5. It can take up to 2 months for fibroblasts to really proliferate and lay down new collagen in a much more organized pattern. And then remodeling stage can take up to four months generally, where you get type 3 collagen is replaced by type 1 collagen, which is much more mechanically resistant. So this makes sense in why tendon injuries are a longer injury to return to normal and have a higher risk of failure if returned too soon. So the anatomy of hamstrings is very interesting. There are 3 main hamstring muscles: your semitendinosus, semimembranosus, biceps femoris, which has both a long head and a short head. Now this is quite a busy slide, but essentially the main thing I want to point out in this slide is that the long head biceps femoris and the short head biceps femoris have 2 different nerves. The short head has a sciatic nerve coming from the common peroneal branch, and the long head has a sciatic nerve at the tibial branch. And we'll talk about why that's important later. So a hamstring injury is a very vague and general term. The muscle that is involved in the injury has a very different function. The different muscles of the hamstrings have very different functions. They're different nerve supplies and obviously different insertions, and that will be relevant for both diagnosis as well as rehabilitation. And it's very important to know the functions and the anatomy. So just a little video on that, just to talk about that a little bit more. So this is the semitendinosus, inserts on the medial aspect of the ischial tuberosity, passes down and into the medial aspect of the medial tibia, the pes anserinii. The long head of biceps femoris passes down and inserts more laterally on the head of the fibula. And as we spin it around to the side, we'll see that it has a short head as well that originates from the shaft of the femur and inserts into the free tendon, a connection at the long head of biceps itself. And that is in that T junction area that we'll speak of shortly. Semimembranosus is a more slender muscle that sits deep to these two other muscles and originates more laterally at the ischial tuberosity. As we spin around again and we separate the muscles, we'll see that the connection between both long and short head of biceps femoris is quite a unique connection, and it's gained a lot of interest over the last number of years with T-junction injuries and why these might be slow to recover. So hamstring injuries are vast in terms of their anatomical location and then in terms of their description. So we'll just run through some of the general descriptions. So an avulsion injury is obviously an injury from either the distal or proximal attachment. Quite straightforward. Microfascial injuries are more at the superficial lining of the muscle layers, very lower grade injuries. Intramuscular injuries are, as it says in the tin, an injury within the muscle itself. Myotendinous junction injuries are injuries at the junction between the muscle and tendon. Intramuscular tendon injuries are tendon injuries within the muscle tendon, within the tendon of the muscle itself. Free tendon injuries are again at the tendon that does not have attaching muscle directly to it. And then T-junction is at the connection between the long and short head of biceps femoris. So essentially just to highlight that hamstring injury is a very vague term, and there is multiple different types of injury, and we need to be as specific as possible in our diagnosis. So in terms of the T-junction itself, what is the T-junction? It's a distal musculocutaneous junction between the long and short head of biceps femoris. It is a much higher rate of recurrence of injury compared with other injuries, almost 50% rate of recurrence. And most of these recurrent injuries are at least the same grade of injury, if not higher. The thought is that there may well be, there are different force vectors, and both of these muscles have different nerve supplies. So potentially there might be an asynchronous activation of these muscles on contraction. So this may well be a reason for a higher increased rate of recurrence. There have been a number of studies that have suggested that early surgical repair of these injuries have a reduction in re-injury and a shorter return to play time. And that has been debated in the literature over the last number of years, but still remains the reason. A more recent study published from Ireland showed that elite rugby T-junction versus non-T-junction injuries didn't actually change return to training times. So still a lot to discover. That group found that intramuscular tendon injuries had a much longer return to play time. Maybe they're a more severe variant. So really, are we hamstrung by anatomy? So the hamstrings involve two joints. They have a huge contraction velocity. They have greater capacity to change length, but they have less capacity to withstand tension as they cross two joints. Tendon tissue heals much slower and differently to muscle. This is important to understand in our return to play times and our management and rehabilitation. Tendons, as we discussed, requires collagen synthesis, requires remodeling with extracellular matrix. So if we come across hamstring injury, what's the assessment? So firstly, clinical. We all know this, but a couple of things to consider. So a couple of mechanisms and factors from the history that might be more suspicious. So if a patient has an audible pop, I think we have to be suspicious, as this might mean that might be intended tendon involvement. The mechanism of injury has been suggested. If there's a rotation at speed, this might be more suggestive of T-junction if it fits with the clinical situation. If there's increase in pain more than 2 to 3 days, if it takes more than 2 to 3 days of pain-free walking, this suggests to us that this is likely a more longer-term hamstring injury. Obviously, if the player continued to play versus was removed, it would indicate to us this is more likely to be lesser degree. We've already discussed some of the risk factors of hamstring injury, and those with hamstring injury background are 3 times as likely to re-injure. Also important to assess in the history is that acute and chronic workload, and has this patient really been exposed to a high level of load beyond what they're capable of. Associated injuries are something to consider as well, so don't forget about the lower leg neurological exam and referral pain from the lumbar spine. Assess the joint above and below, the hip and knee joint. If the injury or hamstring pain is related to the insertion point, consider inflammatory enthesopathy as a potential differential diagnosis. So from the history, some red flags. So pain at the tendon origin, significant bruising, a pop sensation, a pop-eye sign, where you get retraction of muscle, severe loss of function, or distal pain with a rotational mechanism, for me are red flags of a higher grade injury. On your clinical examination, we all know to look, move, and feel. So if we focus in on the move side of things, popliteal angle can be important to assess hamstring length. The maximal hip flexion, active knee extension assessment is helpful as well, in a similar vein. And as we spoke about already, assessing lumbar spine is also helpful. It's important to assess hamstring strength in a number of different ranges of both hip extension and knee flexion, both isometrically and eccentrically. Oftentimes, when you're assessing an athlete on a bed, it can be very difficult to assess them properly, as their muscle bulk can be huge, and you may be convinced that they have no clinical pain. It's important sometimes to consider testing these muscle groups, especially in such athletes, in a more objective manner. And isokinetic dynamometry can be quite helpful in this regard to pick up subtle differences in strength that may be impossible to pick up by manual testing. An Askins H test is a helpful test to assess readiness to return to jog or run. Plyometric assessment and double leg or single leg counter movement jump, drop jump, or biomechanical analysis, again, are important facets to the clinical examination that are often overlooked. So then on to radiological assessment of hamstring injuries. So the classification of hamstring injuries really has evolved over the years. In 1962, the classification essentially was based on a clinical grading. But thankfully, times have moved on since then. In the early 2000s, ultrasound gradings were suggested, and not until 2007 that an MRI-based grading system was introduced. But again, this really followed the initial grade 1, 2, and 3 of quite a basic grading system. In 2013, the Munich consensus classification was suggested, and this incorporated a couple of different factors in terms of clinical signs, location, as well as MRI. But then in 2014, I think a system that we're all fairly familiar with now is the BAMIC classification. And this creates a common language for describing hamstring injuries. And we'll talk a little bit about that over the next couple of slides. But essentially, the important part of the BAMIC in my mind is that A, B, or C, C being an intratendon or a tendon tear or tendon injury, essentially means that there's going to be a lot longer of a return to play time. Grade 0 to 4 will determine the extent of the tear or the length of the oedema seen on MRI, essentially. We'll go through a few examples of that now. So a grade 0 injury in the BAMIC is essentially a normal MRI. There may be some patchy oedema from a DOMS type picture. We don't see too many of these. I think these generally will return to play pretty quickly without much worry. This is an example of a grade 1B hamstring injury. And as we'll see from the video, a small area of high signal, less than 10% of the cross-section area of the muscle itself, and less than 5 centimeters, so quite a small area. So again, shouldn't cause too much problem long term. Grade 2 injuries, again, are slightly different in size, and then a grade 2C, again, is a more of the tendon structure is involved. Cross-section area this time of the tendon is less than 50% of the tendon cross-section area and less than 5 centimeters in longitudinal length. There's no tendon discontinuity with these injuries, and this is a T-junction 2C injury here. As we'll see, the edema in the junction between the long-headed biceps femoris and the short-headed biceps femoris. A subtle injury, but again, T-junction, we know our recurrence rate are higher in those injuries. So important to consider that when managing these athletes. Then as we move on to a 3C, or grade 3 injuries, we can see that there is more extensive edema that involves more than 50% of the tendon cross-sectional area with a larger longitudinal length of involvement. This is in the semitendinosus. There may be lots of tension within these tendon injuries, but no gap will be evident. And then on to the dreaded 4C injuries, which essentially means that there is a full thickness tear of the tendon. There'll be complete discontinuity of the tendon and retraction. And we see this feathering or tail-like appearance to the distal end of the tendon where beyond the tear, with extensive edema surrounding. Ultrasound can be quite helpful when used in conjunction with MRI for certain hamstring injuries. I find it helpful to assess T-junction injuries in terms of prognosticating their readiness to return to play. It can be quite helpful to test on a prone knee bend, a contraction test, to see if there is gapping within the tendon itself. Asynchronous movement means the two muscle groups move separately and are not moving in unison. Ultrasound can be helpful to monitor healing. Now, obviously, there is a different clinical skill set in this, and Kevin Cronin, an Irish radiographer who's vastly published in this area, has many publications in his expert assessment of these type injuries. And I thank Kevin for this slide. MRI is the gold standard in assessing hamstring injuries, and I would recommend that MRI is the first assessment tool in terms of radiological assessment for such injuries. Ultrasound can provide helpful in terms of guided intervention, be it a hematoma aspiration or a potential platelet-rich plasma injection. So what's the relevance of the BAMIC grade? So the initial papers were published in relation to a British athletics group, and they found that the type C injuries had a much longer return to training. There was a significant difference between type 1 and type 3, but not actually between type 2 and type 3 in terms of return to training. Again, there was a significant difference between grade A and grade C, but not between B and C. So not very clear cut. More recently, on the study published in a rugby group in Ireland, they considered that intramuscular tendon involvement was a far greater risk factor for delayed return to training compared to no intramuscular tendon involvement. Their grade C, 3C and 4C had quite a similar average return to training time, and grade 1B, A, 2A and 2B not too dissimilar. Interestingly, this group also found that T-junction injuries didn't seem to play a massive part in time to return to full training. So how else can the BAMEC grade be helpful? We spoke already that it can be helpful to stratify the risk of re-injury. So type C injuries have a much higher risk of re-injury compared to non-tendon injuries. And as well as that, there's been suggestions that they help direct rehabilitation. The rate of re-injury from the track and field group from the initial British Athletic study group over a 4-year period had a re-injury rate of only 2.9%, which is really incredible when we see the re-injury rates of hamstring injuries across other sports. Accuracy in diagnosis is very important to predict prognosis. Our initial clinical suspicion is often wrong. We often get it wrong when we see a player or a patient on a pitch or on a track and predict how long they might be out for. This was an interesting study that looked at the GA cohort, and 72% of the mild hamstring injuries and 46% of the moderate hamstring injuries led to a much greater time loss than predicted. So why are we getting it wrong clinically? Are we pushing athletes too soon back to play with hamstring injuries, and is this a reason for the recurrence rate? We know that immature scars have a very poor tensile strength. We've already discussed the anatomy of healing. And then it leads to prolonged time for the scar to reach full maturity in active muscles, and then it re-injures. Chronic scar formation doesn't have the same capacity to develop power and contract with the same level of force. It's reduced compliance, changes of biomechanics, and of course then it leads to an increased risk of re-injury. What is the rate of recurrent injuries? So over a third of GA hamstring injuries are recurrent injuries, and over a third of these recurrent injuries are happening in the first 2 months of their previous hamstring injury. 13% of elite rugby hamstring injuries have been documented as recurrent injuries, and almost half of this group suffered another hamstring injury within 12 months. Half of them within the first 3 months of injury. So can we do better? So I suppose we can't change the non-modifiable risk factors, but we can change the modifiable hamstring risk factors. And I'm not going to go through the slide in detail, but essentially these are a number of factors that we really need to try and modify to reduce this risk. Keeping the athlete at the center of this is important, and I truly believe that a full multidisciplinary team managing of these injuries is really needed, as we know that it's not just biomechanical and mechanical factors. There is a number of other factors at play as well across a number of different domains of healthcare. I'd like to direct everyone to have a read of these papers and consensus documents if they haven't already, essentially published in 2023, which outlines the consensus group in the UK on classification, operative management guidelines, and as well as consensus guidelines in rehabilitation, running and return to sport, both made up of clinical specialist physiotherapists, sports medicine physicians, and orthopedic surgeons with expertise in hamstring injuries. So well worth a read to update yourselves. So in summary, understanding hamstring anatomy and healing is really vital for management. The clinical assessment, listening, watching, and carefully examine is again key part of assessment. MRI truly can provide a definite diagnosis and help risk mitigate. We're very lucky here at the Sports Surgery Clinic UPMC that we have an incredible team of musculoskeletal radiologists that are very skilled in assessing our hamstring MRIs, and they're great colleagues to work with, and we have many case discussions on difficult cases. Really following evidence-based rehabilitation is key, and return to play guidelines are really important as well. Working together with the athlete at the centre, as we discussed, is probably the most important part of all this. We don't treat the scan, we treat the athlete, but the scan, in my mind, can help give us more information to make decisions on return to play and rehabilitation pathways. So thank you very much for everyone for listening, and happy to field any questions at any stage.
Thank you very much, Roland. So what we're going to do is we're going to move on to the next speaker, and then we're going to come back and bring Roland and Stephen in for a discussion at the end. Without further ado, I'm going to invite Stephen McAleer. Stephen currently works with Red Bull at their Athletic Performance Centre in Salzburg. He works across a broad range of athletes clinically, and he's the lead for global soccer integration of the clubs with Red Bull Network from the medical and physiotherapy perspectives. Prior to his current role, he was first team rehab physiotherapist with Tottenham Hotspur Football Club, being part of their 2019 Champions League final campaign. Previously worked with Brighton and Hove Albion Football Club. And Stephen also works as physiotherapist with British Athletics for the Rio Olympic Games cycle. He's published papers on chronic pubic pathology, hamstring rehabilitation, and rectus femoris epidemiology. And Stephen is due to take up a new role with Chelsea Football Club next month as the lead of rehabilitation, essentially managing Chelsea's rehab department. So we're delighted to have Stephen, who's going to talk to us about rehabilitation and from hamstring injuries. Thank you very much indeed.
I really thank you very much for the invitation. I got asked to do a 12-minute presentation on hamstring injury management in terms of rehab. That's why I titled it a whistle-stop tour. So apologies if I go across something very, very briefly. We'll have time for questions at the end, but I'll try and some of the topics you would need a full time to present really. But let's open up the topics and then we can chat further. This is our centre here in Austria, by the way. So this is our gym and where we work. I'm going to go straight into hamstring function. So in terms of, from a functional point of view, in terms of particularly around sprinting, biceps femoris probably undergoes the largest strain. So really important in terms of acceleration and the terminal swing, and strength at long length is incredibly important for it. This is why I think we see so many injuries within it. Semitendinosus, important for lengthening velocities. So I think it's really, listen, it's a semitendinosus, it's not called a tendon for no reason. It's really important with these lengthening velocities, and it's important for max velocity. Semimembranosus, big force producer and really incredibly important during stance and the swing phases. And then the adductor magnus, again, very important for force production and particularly driving from flexion into extension. Okay. I think it's important, but when you get the kind of complex hamstring, chronic recurrent type guy or girl, just think about the contributing factors into that, because it drives me crazy when someone comes in and they've got posterior thigh pain because it's not a hamstring strain yet, and someone goes in and looks at the hamstring straight away. It's your straight hamstring strength testing, length testing, palpation. Listen, look at their lumbar spine, look at their hip, look at their ankle, and then come up and look at the hamstring. Okay, but address the contributing factors or look a little bit more holistically. So same things like muscle pathology. So the guy who's had a big muscle tear previously, that might be an atrophied hamstring or with scar tissue, and you can use imaging modalities like Ronan spoke about to look at that. And intervention then would be something like eccentric loading or hypertrophy type work. Lumbopelvic strength and stability. This is a controversial one within hamstring injury and muscle injury stuff. And Jordan Mendicuccia has published some stuff to this the last few months actually. And he's done a good attempt to try and quantify it. It's not good science, and let's be perfectly honest about it. It's incredibly difficult to assess it, really difficult. So, but what I can say, so if you're saying evidence-based practice and stuff about lumbopelvic control, there's not a lot there. But what I can say, and having worked in track and field for a while, for a good period of time. There's not one decent sprints or running coach that is not addressing lumbar pelvic control during running with their athletes. Not one. So assessment of conditioning or trunk within many variations, and be going on to a specific program. I'll talk a little bit about the hip joint, and Pat, I can see him licking his lips already, getting excited. But hip joint, when you get these guys with the big cam or pincer deformities, they can't get into a big enough range. And when they're doing a lot of work, particularly axle type stuff, it's really difficult for them, and they flare up. And then hamstring, you start, particularly medial hamstring, you start to get awareness. So I think it's good to be on top of what your athlete has, and knowing what their sort of what the morphology has, what they have within the joint, and weekly therapy type and monitoring of their hip range of motion, staying on top of it as much, because you're not probably going to improve someone's with FAA, you're probably not going to improve their range, but staying on top and giving them as much of that range that they have, making it available to them. And also things, again, I'd be really interested to get Pat's opinion. Some injection therapies, maybe something like Ostenil for the hip joint. I don't know, good or bad, I'm not so sure, but what I can say is people are doing it as part of their hamstring injury prevention, for want of a better term, type work. Again, spinal pathology, incredibly important within hamstring work. We done a study, an internal study, I would say, on muscle injury incidents and the causes or things that contributing factors around that. And we had about 3 things that were associated because the numbers were so low within our group. The funded guys wasn't a big group, but over a 3 or 4 year period, we had 3 things that were associated. One was a PB, they've ran fast. Essentially, their body's gone to a new place in that period of time. They're vulnerable in the next week or 2 after that. 2 was long haul travel, and particularly frustrating for us would be they tend to go on training camps where either America or maybe wherever, somewhere else, South Africa. And I get off a flight and it's warm and the track is really fast and it's lovely and hard, and they'll go out and absolutely hit it. And the first week it's like, there's a sniper sitting in the stand. It's just lots of muscle injuries. So that first few days, week needs to be nice and calm and progressive within that. And also then the third thing was back pain. So just bog standard simple back pain. If they had a stiff back within that week, those are the days you need to sit on top of and make sure that improves. So again, injection therapies, imaging, knowing what they have, some regular monitoring in terms of their neural mobility or compliance, things like that. Then I'm going to speak about possible adaptations. Then this is the actual, before we even talk, this is the hamstring itself. So we've all these different things within a hamstring, architectural changes in terms of atrophy or scar tissue. Strength at long length seems to be really important. Fatigue resistant, they need to have strength endurance. And you see the guys in the last 10 minutes of a game or whatever, and they pop, there's possibly an element of fatigue there. Neuromuscular inhibition following an injury or some type of spinal awareness or neural problem. Elastic function, metabolic function, neural recruitment, and patterning. So these are all qualities that a hamstring needs, and these are the things that you need to think about within your rehab, the adaptation that they might actually need. So when you say, I'm doing hamstring rehab, and they're doing their eccentrics, they're doing Nordics, and they're back running, that's nice, but there's probably more things that we need to probably think about and trying to add into the puzzle. And how do we acquire those adaptations? So like for capacity and cross-sectional area, hypertrophy type strength plan work in terms of programming, blood flow resisted training, and then strength endurance stuff to try and get their capacity up. Force generation, maximum strength work. So we do a lot of, certainly I do a lot of high force isometrics and obviously eccentric loading. And then go into something like reactivity, high force isometrics again, if you can adapt them a little bit and make it more reactive. Plyometrics themselves. And the number one, sprinting, we have to get back into sprinting within our rehab because that's how we get things going. Then in terms of a functional progression of a hamstring back to running, I'm really sorry I don't have videos because they don't come across very well online when you do an online presentation, but I'll talk a little bit about some sprint drilling benefits or why we use them. So you can see David Ovar's paper there talking about post hamstring injury, the EMG and the coordinative pattern seem to be adapted. And sprint drilling can help get that pattern hamstring group again improve within function. You can get high forces and contraction velocities whilst doing sprint drilling type work, but in a safe, controlled manner. And I think that's why it's an early indication for rehab. That's why I use it certainly to get those patterns again, but at a low risk rather than getting out running. So I will start drilling pretty early in some cases. We'll talk about it in a second, but even as early as day 2, day 3, within some type of certain types of hamstring injury. So within that, the key principles is, again, I probably look high and low. So through the torso and the trunk, are they able to control that torsion through the trunk and able to transfer force through it? Nice bit of ground contact. So ground contact is absolutely, the feet tell an awful lot about what's happening with the sprinter. So this guy's a hugely powerful hip guy. He's so strong, but can he transfer that force into the floor via his feet? And when those guys can't, they waste energy. And then 2 things: there's a performance deficit. They're running slower, but 2, then they're susceptible to injuries in other areas. So switch from flexion extension and key principles. And Chris Bram has done some nice work looking at running mechanics and being able to quantify that. And his work is actually really nice. I'm going to talk about now, obviously Rowan talked a little bit about get that out of the way, about the different types of hamstring injuries. I'm going to only speak about the BAMIC stuff just to give a little bit more, I guess, context. Listen, I worked with the Bristol guys. This is what I use probably in the morning on a daily basis. With the myofascial injuries, they're characterized by faster recovery, low re-injury rates. So what I'm doing with them, I'm being pretty aggressive, to be perfectly frank. So really early manual therapy and really early return to function. So I'm probably drilling them around day 2 or day 3. Now, they're not running fast, but they're doing walking drills. They're doing some type of movement, getting back in. I'm very aggressive with my myofascial injuries. And this is why I'm talking about my relationship with the radiologist is incredibly important. If I'm on the pitch with someone, for example, and we're right on the edge, so say I would have got a game or something to get back for in time. If I'm going for that and we're going for that, we're right on the edge. And if the diagnosis is incorrect, I'm hedging my bets a little bit. So my relationship with my doctor and my radiologist has to be super tight, because that's where, you're going in with 1 foot in and 1 foot out. You're not really committing to it if you're not really confident in them, because if it blows up, and listen, I've worked in lots of football clubs, but re-injuries, rehab's not a good thing, and you'll hear some noise about it. So really important getting on top of the diagnosis. But in general, myofascial, we're being quite aggressive with them. True. With the class B, this is kind of more typical traditional rehab, I would say. So early drilling, dynamic drilling from around day 5, and gym loading is periodized throughout the rehab. So this is the classic, hamstring rehab that we would probably more normally assume and see and know from previously. Then our class C, listen, Rowan went through it all, but slower recovery and higher re-injury rates, and this tendon healing and type 1 collagen seems to be slow. One thing I will always say to you is that these guys, you could be prognosing 8 to 12 weeks or something like that. Around week 5 or 6, they're going to be feeling amazing, and they're going to be going crazy at you. Why aren't you letting me push on? Because the healing and adaptation is going to lag way behind function. So when you re-image these guys, and we'll talk about that in a second, it might not look that nice. Whereas they're getting through their work quite well, and then you have a bit of a situation you have to try and talk about and work it out. So with these guys, you're doing restricting the early tensile and elongation stress, and you're going to have to respect the healing time. Okay. Then this is more talking about a kind of a mesocycle, a weekly planning on a pitch. This is a biceps femoris from 3C, from a player who I used to work with. This is how I kind of structure my week. So I come in on a Monday. The guy will be off. So say if you're working on a typical Monday to Saturday, off on a Sunday, we'll try and do that within the rehabs. Early Monday is a kind of pitch re-intro, getting them moving again after the day off, and low enough volume, low enough intensity, getting them going. Tuesday then is the day when I hit it because 1, they're fresh, they've had a day off Sunday. 2, they've been almost an activation on Monday, and then Tuesday the day to run fast. So this is when I will run flat out, to be perfectly honest, or where they're restricted at within their rehab. And then I will do a double hit of lower body gym then in terms of eccentrics work and isometric work. Because if they run fast, it is eccentric work. And if you wait for another day to get another hit of eccentrics in the gym, it's not all that useful for you. So I'll probably double that up, and and you also get a more resistance to fatigue and things like that. Then on this Wednesday, because they've ran fast the day before, I'm going to bring their speed way down, but I'll give the volume because it's safe, it's aerobic, it's lower intensity, and you can be, comfortable that you're not going to do anything that's at an intensity that's going to hurt that hamstring again whilst they're a bit fatigued from running fast again on the day before. Thursday they'll be off feet, so do a 3-3-0-2 kind of a cycle. And then Friday I'll do my speed endurance type work. So they're not fresh because they've had a week's training almost under the belt, but speed endurance, lower intensity, but still running fast. And I'll get plenty of volume. That you're looking around 500 or 600 high speed running in this case. Saturday I'll top up in terms of whatever they need for the rest of the week in terms of accelerations, decelerations, and volume, but it's probably more of an accel decel day, hard eccentric day in terms of eccentric strength. Also again on the Friday I will do their hamstring eccentric work again. That will be the day when I do that. Let's talk a little bit about specifying the return to play for each kind of category of injury. I guess as the complexity of the injury becomes more so too should become the return to play criteria. So with the class A's, might be looking on ultrasound maybe, but essentially I'm going very clinical. Their range of motion back, their pain and palpation, their contraction awareness, and also their askling negative, and they've cracked through their work and done quite well. With the class B's, yes, clinical assessment, but you're adding more of a strength component within that too. So whether that's isokinetic or NordBoard or whatever you have, I think it's an important component within the class B's to have a strength diagnostic to see where they're at. And then the C's have the whole gambit. They've got clinical assessment, strength assessment. Within our running guys, we've got some biomechanics, looking at ground contacts, stride lengths, things like that. And also, before we start going at very high intensity, I am re-imaging. So seeing where they're at that moment in time and taking it from there and getting out. But what I'm saying is not one of those will determine, okay, if his MRI is really bad, but everything else is really good, that won't just determine the course of the rehab. If the MRI is an absolute bomb site and it looks terrible, then yes, maybe that would, even though the other stuff might be good, but usually that's not the case. But it's one part of the picture, and that's really important to have that awareness of return to play, getting a broad, holistic viewpoint of the injury and where that player is at that time point, and then deciding as a group where we're going. Yes, are we pushing on, or do we need to hold back a little bit? So I went through that really quickly, but key things for me are accurate structural diagnosis and consistent terminology, and that's why using the classification is very good. And like I say, that accurate diagnosis is incredibly important from the doc side and the radiologist before feeding into me, because that's if it's go time on the pitch and the player's not ready, then it's going to not go well. Be consistent in addressing the contributing factors, looking around and looking a bit more holistically. Respect the healing physiology of the tissue involved and tailor the rehab to the tissue involvement. So, but to see maybe less elongation stress later, a bit more aggressive with the A's, things like that. Probably one for the physios, the exercise prescription has to reflect the desired adaptation. It drives me crazy when I look at plans or rehab plans and yeah, we're working on this, and then this is the plan, and the plan does not reflect that as a priority at all. And that might be the need strength work, so you do have to do less on the pitch or less running or whatever the case may be. But please, you need to reflect what you're programming in the adaptation that you're trying to achieve. And too often, particularly physios, that there's a mismatch there. And the return to play criteria returns or elevates with the complexity of the injury. So like we talked about with the A's, the B's, C's, there's a bit of a cascade or a step up there in terms of the amount of assessment before returning to play. And those are my contact details if anyone wants to get in touch. And thank you very much.
Thank you, Stephen. That's great. It's great to get that perspective from a professional perspective. You know, with you dealing with these high-level clubs. You know, so we definitely want to talk more about that. So we are running tight on time. We may run a little bit over because I think that it'd be good discussion to have with you guys. So I'm going to ask Karen just to present just the summary of the paper that we'd offered for people to read, and then we'll come back in for discussion regarding the paper and with yourself and Ronan. Thanks, Karen.
Yep, so thanks very much, guys. Today's paper is a comparative video analysis of hamstring injury mechanisms and situational patterns in men and women's football. This study was conducted by Della Villa et al. Last year as part from the isokinetic group. And the first aim was to describe the injury mechanisms and situational patterns of severe hamstring injuries in female professional football players and then compare them to their male counterparts. The second aim was to report seasonal, match and pitch distribution of hamstring injuries for both groups. The male data collection that they done was part of the sub-analysis of their previous paper. They looked at online database, they conducted searches for player-specific injury details on the history and when they occurred. They only included injuries that resulted in a time loss of greater than 28 days. Similar then for their female data collection, they looked at online databases to get their information, and the same hamstring injuries greater than 28 days were included. The video analysis were obtained, or the videos of the games, I should say, were from online digital platforms on YouTube, and processing was done on a cloud, whereby they cut the video or the injury to 1 minute before what they thought the injury was and 30 seconds after the injury frame. And they did obviously look at replays and television broadcasts as well to support their decision making. The videos were analysed using Kinovate by 3 reviewers. Injuries were categorised as non-contact, indirect contact or direct contact, while situational patterns were defined as running, overstretching in open kinetic chains or overstretching in closed kinetic chains, kicking, jumping or other. They also recorded the month and the phase of the game, the number of minutes played by the injured athlete and the location where the injury was recorded. It's quite an exploratory study, so there wasn't too much statistical analysis done, but they did compare the groups, male and female, for categorical variables using chi-squared analysis or t-test for any continuous variables. So they had 64 hamstring injuries in female athletes and 65 in males, but as you would expect, they had video footage for nearly all of their male injuries, but only video for less than half of their female injuries. There were specific differences in terms of the injury, whereby females had 2-fold higher proportion of indirect contact injuries than males and a lower proportion of non-contact injuries compared to men. For indirect contact injuries, all of the female players involved in an external force to the upper body before or at the injury frame, while half of the indirect contact injuries for males involved an external force to the upper body. In females, there's also injury predominantly affected the injured leg, while males, the uninjured leg was more commonly involved also. Situationally, 3 in every 5 injuries in females and 2 in every 5 for male occur during running. Overstretching type injuries collectively account for almost half in males, but only 1/5 in females. And kicking injuries accounted for 1 out of 6 injuries in females and 1 out of 10 in males. Figure 2 was just where they described the types of injuries on video footage that they were identifying. And when you look at the situation or the seasonal distribution, you see that females had kind of a more even distribution across the year, apart from March, where you see
with a guy that was actually quite strong. You know, there's incredibly strong athletes out there that will convince you clinically they're absolutely fine in a bed. One in particular stands out for me, who I had to assess him on the floor. He was too tall for the bed. His hamstring was the same size as my waist, and he had a 4C. And if I didn't see his MRI, you know, I would have thought this guy is making this injury up. And he had the biggest hamstrings I've ever assessed. He didn't end up going for surgical management. We had a discussion with the surgeon. He's a high-level athlete in his own right, but has set PBs, national records since then with the 4C. So like MRI is, I'd agree with Stephen 100%. MRI is not your is your diagnosis, is your accurate diagnosis, but doesn't determine everything for you. It paints part of the picture. For me, you've got clinical, you got functional, and you got structural. Clinical is your history and exam. Get detailed with your exam. Have the subtleties. If there's pain, if there's tenderness, hold, don't push. Function, assess strength, have handheld dynamometer if you can get one. You know, it's not great, but it's a little bit cheaper than maybe the isokinetics. Create a battery of tests that you can assess strength, especially with your high-level athletes. Your arm, unless you've got a huge bicep, is unlikely to be able to beat their biceps femoris. And then structural. Ideally, you get MRI imaging from a structural point of view. Ultrasound, I think, in a skilled hands might be able to pick up a lot of the injuries, but will miss a lot of injuries as well. MRI is your gold standard for diagnosis. So yeah, you know, I think from the clinical point of view, those few red flags would be reasons I'd be getting someone for an MRI and trying to get them in quickly, because the longer you leave it, if they're outside a surgical window, you might not, you know, they might not be an appropriate candidate then if they're too late.
One other very small clinical thing is if you have someone whose range of motion you actually know quite regularly, who you assess, if after some type of hamstring injury their range of motion has increased, a big injury as well, because probably there's probably no tendon there to stop the range of motion. So I've seen that a couple of times. Like, oh, my range is great, and it's like, yeah, it's great, but that's not a positive in this instance.
Okay,
interesting.
I've got just two last little points, guys, and we're running out of time here, so we have to be very quick in this one. So, what are both your views on using Nordics in terms of rehabilitation? And so it was a question just regarding the use of Nordics as part of rehabilitation.
Nordics is an exercise, to be perfectly frank. It's an eccentric exercise, probably more focused on the distal end of the hamstring. That's all it is. The problem with Nordics is that it's been used as the only hamstring test because it's an eccentric test. And then because it's in the literature a lot, everyone thinks that what you need to do is Nordics. It's a distal eccentric exercise. Nothing more, nothing less. I use it sometimes, I use it not other times. It's just because it's used in the literature so much, there's so much talking around it.
And that, yeah,
agreed. I think it's, yeah, agreed 100%. And you know, it ticks maybe one of the boxes of modifiable risk factors. It ticks your eccentric strength and the distal. It doesn't tick any other box really. Helpful if you have it, but not the only test, as Stephen alluded to as well.
And a lot of people don't tolerate it very well.
And the last thing is just, I noticed in both your presentations, you mentioned about the significance of intramuscular tendon injury regarding a higher re-injury rate and longer return to play. Just to throw a can in the worms, we've just undertaken a systematic review of meta-analysis on that very particular topic, and we found that the widespread evidence supporting that was not there, and that's just been accepted for publication. So although there seems to be a feeling that this is the case, the evidence is very low quality supporting that. So any comments on that, guys? Even from your own experience, or you know, when you look at the evidence, is it really there?
I don't mind trying. Ours is difficult. The stuff that we done with the BAMIC is very difficult because it's hard to do that level of work in high level sport, because you need to give athletes the best level of care, or else you're not going to have a job. So if you're trying to do a proper systematic scientific stuff, it's very difficult in elite end sport, and that's probably the difficulty that we've had and the stuff that we've published.
Yeah, and I think I'll come into that as well. Like the Irish group that published recently, it all depends, I think, on your patient cohort. Elite international rugby players versus social club players are two different animals, two different size hamstring muscle. An intramuscular tendon injury in an international rugby player with a massive biceps femoris muscle to support and splint that tendon, and clinically trying to pick up that is very different than a different cohort. So I think you have to treat everyone individual essentially, and a 3C and a 3C in a club player and a 3C in an international player is two different injuries. It comes back to that function assessment as well, like what can they do functionally. Again, the MRI is part of the picture, not all of the picture. But yeah, it'd be interesting to see that systematic review when it comes out. But it'd be interesting to see what was the patient cohort.
Okay, guys. So the final question is back to Karen's presentation, just on the video evidence. I mean, the difference between mechanisms of injury and sort of the situation of injury regarding male and female athletes. And so we haven't had time to really go through and drill the methodology in that paper, which has a lot of limitations. But any comment just on the difference between the incidence, the mechanisms of injuries between ladies and males?
I think it was a nice paper. I might mean that. Like it was a nice paper in a way, because the female injuries are not assessed enough in the literature, and there's definitely a huge disparity in terms of male versus female. So it was great to see them included, the female injuries. On that, I suppose the rate of female injuries and non or indirect contact hamstring injuries was far greater, it was almost treble that of the males. So like in terms of neuromuscular control, perturbation and whatnot in females obviously is a factor there, as well as the fact that like their injuries seem to be much more common in the latter 15 minutes of matches. So you're as Stephen said in his presentation as well, that endurance, strength endurance, and towards the latter end in terms of the female athletes seems to be something that really needs to be looked at. I suppose the challenge of the paper as well, that the data was collected from publicly available platforms and media. It's a huge limitation. There's huge context to players returning to play, in terms of selection criteria, in terms of, relying on the media to give you your data on return to play times is probably not the best way to assess it, and more kind of widespread data collection across sports would be more beneficial to get a more accurate reflection. But at the same time, I think it did highlight a few interesting points. I think just a point as well, I think in the chat box that Nicole van Dijk actually has popped in a more recent paper as well on a similar vein that Nicole and his group have published as well. So that might be of interest to some listeners as well.
Stephen, finally, any comments on the differences between male and females regarding hamstring injuries or even rehab? I know you're male athletes, but just any comment?
No, well, it was in track. We used to have a big mix. So, and the paper I done on rec femmes, we had 4 surgical repairs of rec femmes. All 4 were girls, and it seems like the girls have bigger tendencies for big intertendon injuries, big blowouts. Don't know why. That was a paper over 10 years or 9 years, I think. And listen, low numbers, low data, and all the rest. All I can tell you is we had 4 repairs that were all female over 10 years.
Okay, guys, we're going to have to leave it there. We're well over time, so rather than holding everybody, we'd love this. You could talk all week about this, so Roland, thanks for giving us your time, and very much appreciated the presentation at the beginning. And Stephen, again, thanks for coming on. And